It's nice to be here today. We're coming to you from the second annual Peds GI Connect in Fort Lauderdale, from the Diplomat Hotel in Hollywood. And my name is Amanda Muir. I'm a pediatric gastroenterologist at the Children's Hospital of Philadelphia, and I'll let my co-hosts introduce themselves.
Thanks so much for having us here today, and happy to join you, Amanda and Umber. I'm Rajitha Venkatesh. I'm a pediatric gastrologist at Nationwide Children's Hospital in Columbus, Ohio, and excited to talk today with my co-hosts.
And hi, thank you guys for having me here today. My name is Umber Langshaw. I'm a pediatric gastroenterologist here at the University of Miami in sunny South Florida. So welcome to our hometown. And we're here to kick off EoE talk.
And so we thought we would dive in to the Eosinophilic Esophagitis podcast by starting to talk about some of the new American College of Gastroenterology guidelines that just came out. And I think one of the things that was in the guidelines that was very clear is that we need to get adequate biopsy specimens for our patients in order to adequately diagnose them and not miss the diagnosis. After we're putting a child under anesthesia, we want to make sure we get enough biopsies. And the current guidelines are recommending 6 biopsies from the esophagus, making sure you sample all the levels of the esophagus. And I know, Umber, you have a personal story that I think would be interesting for everyone to hear about your family.
Yeah, so luckily or unluckily, my husband and son both have EoE. And my husband's story is he was having food impactions on and off since age 17. And finally got a scope at age 25 out in the community. And when he had the scope done, he was told he has a Schatzki's, I always say it wrong, Schatzki's ring, and was dilated and was sent home, and no biopsies were taken. And a couple years later, symptoms progressed again, same sort of story, had another dilation done, no biopsies done. And now by this time I had finished med school and residency, and so was like, this is not right. This is not normal. And he actually went to a friend who's an adult GI who was going to do the same thing until I told him right before he went in for his scope, can you please, for the love of God, do some biopsies? And it came back that he had greater than 100 eosinophils in each high power field for the 3 biopsies he took. So that was very interesting to see the approach to biopsies in the adult world, I think. And then on the flip side, my son, who had no dysphagia, no symptoms other than poor growth, at some point we had labeled him the picky eater of the family, and he wasn't gaining weight and wasn't growing well. And we said, okay, time to get evaluated. And he got a scope, got 6 biopsies, and was found to have eosinophilic esophagitis at age 11. So, symptom presentation different, age group different, but the importance of biopsies, I think, is the message here.
And I think the importance of biopsies, even in the setting of a normal appearing mucosa.
Exactly.
Because we know that 20% of esophagi will look completely normal, and there will, in the setting of eosinophilic esophagitis. And so making sure you take biopsies, even if the esophagus looks normal, if EoE is on your differential, is important. I feel like sometimes when we're doing our scopes and we get our 2 biopsies, because that's what we do as pediatric gastroenterologists, the patients with failure to thrive are the ones that probably don't get biopsied because your index of suspicion isn't quite high enough if they're not super atopic or they're not having overt dysphagia. And so patients with these subtle symptoms are probably the ones that aren't getting adequately biopsied because our index of suspicion as endoscopists going into it isn't quite there.
And having a mom as a PDGI who didn't, again, think of it either, just thought you need to eat more. Like, come on, like, what's going on? Or you're the picky eater, labeling that child. Obviously, you feel bad as the mom part. Yeah. But it's a learning lesson that you should definitely biopsy when the mucosa looks normal, and you just don't know how it's going to present in each patient. Yeah. So I am happy to report that my husband's EOs, he recently had a scope done. He's on a PPI and inhaled/swallow steroids. And he has less than 15 EOs per high power food. So he's being treated adequately and no more dilation since that last time when he had a lot of EOs present. So
that's great. And that also means that he's gotten his follow-up endoscopy, which is also really important. I think sometimes we fall into a trap of, oh, they feel so much better. They started gaining weight. Their dysphagia's gone. We don't need to scope you right away. I don't know how often you do follow-up endoscopies, because this is a hot topic in EoE right now.
It is. Yeah, absolutely. It's a great point, because I think particularly in that first year after diagnosis, trying to think about, you really are front-loading a lot of the scopes, particularly with like dietary therapies, for example, and really trying to be thoughtful of not having to do repeats a day endoscopies, particularly in children. So I think that definitely factors in a lot of how we approach it, and as a parent and as a doc as well, to really be cautious about thinking about that, but also importantly that we know we need to monitor, and obviously even for patients that do feel amazing, unfortunately it doesn't match necessarily macroscopically in the esophagus or histologically. So that's been a really critical piece of even from our practice of trying to be cognizant and thoughtful and proactive of making sure we reach out to patients and families.
Yeah. And Elizabeth Jensen had an interesting paper that came out recently thinking about, you're talking about front loading these scopes and having so many scopes when you first get diagnosed, because you have to find the therapy that works.
Right.
And in her study, she was looking at psychological comorbidities in eosinophilic esophagitis. And one of the things they found is patients within the first 6 months have more anxiety, more sleep disturbance, and how much this increased procedure load factors into that. I missed school, I missed my soccer game, and how much the stress on these pediatric patients from procedures and medications out of the gates is factoring into that. We just don't understand other than this one paper. So I think thinking about the patients holistically as they go through this journey, especially in the beginning.
Absolutely. It's such a great point. And we are fortunate to have GI psychologists that work as part of our team, but absolutely a huge challenge and burden. And also trying to think of, with EoE, that not having a biomarker, that we could readily access or use like in other diseases. So not really having stool or serologic testing that we can use to really monitor. And I think what we've been really fortunate, I think even, thinking about the past decade of just like, or past several decades, things have just so rapidly advanced. So it's been a really exciting time to sort of see how this has grown, and, thinking about the string test or thinking about like transnasal endoscopy as ways to limit sedation for our patients.
And so do you want to just go into what transnasal endoscopy is and how it works in your clinic, since you do a lot of them? Sure,
absolutely. So, the transnasal scope is essentially an esophagoscopy that we are using a much thinner scope. There's different versions that are available in the market, but essentially you're able to go in through the nose and then into the esophagus and take pictures and biopsies that we're actually, are incredibly informative, similar to a sedated endoscopy in terms of understanding macroscopically what we're seeing, and also in getting adequate biopsies and knowing that that actually can help us decide management. And so for our patients, generally speaking, I've done it in children as young as 6 and above, and I've certainly had colleagues in other institutions do them even younger potentially as well. But it's been a great option, especially for those patients that have had many scopes or need several scopes to help reduce that burden.
How do you choose which patient because I feel like there's patients that are, even though they're old enough or maybe know the burden, are not going to be amenable to doing a unsedated scope. So what makes you choose which
It's a great
patient?
question, because I actually, so the Colorado group, Natalie Wynn and the folks there have really pioneered this. And I think, the biggest piece is I do them for our practice. So they may not be my patient. I might meet them for the first time that day. And so I say that in the sense that I'm always open to sort of thinking about it for a lot of our patients. In general, though, just they do need to be able to sit still. And they, the procedure, I think we're down, I'm not sure where Matt is, but like somewhere in that 3 to 5 minute range of getting it done. But, for a lot of the patients, I think when we think about even the ENT world, they may not even know that they're getting a scope with our ENT colleagues until they get there and do great. But I think for ours, because we, do have to do a little bit of prep, so nothing to eat or drink for 2 hours, trying to sort of navigate who would be the best candidate. And honestly, I find that even sometimes anxious patients do really well because they are able to breathe through it and work through it. We do use things like VR goggles to help with distraction as well. I know the Colorado group also has looked at other factors, including in addition to age and gender, but also things like using nasal sprays. So just in my own practice, I do have my patients use a nasal spray before because we administer a lidocaine spray topically through the nose and into the back of the throat. So sometimes that can seem a little disconcerting if you've never had that sensation before.
So you tell them to do nasal spray to practice or to clear to?
It's a great question. I do it for both. Yeah.
Both.
So I have them sort of front load that right before the procedure, the days leading up to it. So that way they're helping to clear their congestion, but also just to have that practice of having that.
That's a great idea.
Yeah. But with that in mind, if they haven't done it, in theory that they've actually done great with it. So we've been very fortunate that, our patients, it's been successful, but, it is a little bit of like when you're there trying to sort of troubleshoot a little bit too. But I would say for most of our patients, I think they're, often get it again because they realize how beneficial and, they can get right back to work and school. And, it's almost like a clinic visit rather than a true sort of sedated pre-op, post-op type of procedure.
My bias is that I don't like to recommend transnasal endoscopy for patients who are having a significant dysphagia burden when I haven't done a regular scope in a long time. So if I haven't been in there myself, because I do think the one downside of the transnasal is that we're not really assessing the esophageal caliber.
Agreed.
And so I think that is something to keep in mind. While this is a wonderful thing and the patients really like it sometimes, and they're like, oh, well, I can just get my transnasal and go right back to class. There is a weakness. And if you want to try to get to the bottom of some of those dysphagia symptoms, doing a sedated and really assessing the diameter.
Absolutely. I think you hit the nail on the head that I think with any of these tools in our tool belt, like kind of thinking about when is the right time or what would be the right tool and what you're trying to look for. So, there are absolutely limitations. So if I'm thinking about doing endoflip or if they're more symptomatic, I tend to gear towards a sedated procedure, but maybe in between, if things are going better, then, that's also how I approach our string test as well. And thinking about, as a barometer, it sort of gives us a little bit of a clue on insight on inflammation, but it's not definitive in the sense of if I need tissue, if I need to assess a caliber, I'm not able to do that in that sense. So absolutely, it's a great point.
So thank you guys so much for your perspectives on both from the perspective of your family and making sure we get adequate biopsies, and also thinking about other ways we can sample the esophagus because we have to sample it so often. And this has been a wonderful discussion. And thanks so much for coming.
Thank you.